slide on the exam. So information about, let's see. So femur. The femur is the longest bone of your body, and you have 3 secondary ossification centers proximally: the head, the greater and lesser trochanters. Those, as I've probably said so many times, are sight. Again, those will be there whether or not the muscles are pulling on the bones, because they're secondary ossification centers. Things like the intertrochanteric line and the epicondyles, those are there because the muscles are attached to the bones there, and they're pulling on the bone and enlarging the bone there. Anteriorly, the shaft is very smooth, but you look on the posterior side, you have this long line that's called the linea aspera, elevated ridge. That's what it translates to, the line that's aspirated up. That's the origin of your vastus lateralis and vastus medialis of your quadriceps. So they originate there and wrap around to the front, join on the patellar tendon to insert to the tibia. So every time you extend your knee, this line gets more and more prominent. The adductor tubercle tells you that adductor muscles are attaching there. The condyles are the smooth surfaces that will articulate with your tibial condyles. And there's a space in between that's called the intercondylar fossa. That's where your cruciate ligaments will attach to from the tibia to the femur and attach in that space there. The small lines like pectineal line, I'm probably not going to test you on, but the big structures, the linea aspera, the gluteal tuberosity and the pectineal line, those you'll have to learn when you're learning the insertions of those muscles. But I probably won't test you on their identification on the bone. The patella is a sesamoid bone. It develops in the patellar tendon. I was just reading something, I forget what it was. I think it was some email my brother sent me, and this, did you know, all these funny things, and one was that babies don't have a patella. It doesn't even show up till about age 2, and sometimes not even till age 6, and I thought, yes, everybody in 301 knows that. So you take an x-ray of the baby's knee when it's born, and there's nothing there. There's a tendon there, but nothing shows up on an x-ray because x-rays just go right through that tissue. So this will develop in the tendon. The collagen of the tendon will be surrounded by bone. So all those little openings that you see in the patella, that's where bone formed around the collagen of the tendon. On the posterior surface, you have hyaline cartilage there, and that will create a smooth surface for the patella to move on the facet of the femur. So right here, this patellar surface, sometimes referred to as a facet joint, and that's where the backside of your patella will be moving. So posteriorly, nice and smooth, there's hyaline cartilage for smooth movement. Anteriorly, looking roughened up because you have pulled this out of the tendon, and so the remnants of where the tendon, the collagen was, will appear as holes in the anterior surface. Okay, putting the two lower bones together, They're kind of mismatched as are radius and ulna. The weight bearing of the femur goes directly to the tibia. The weight of the tibia transfers directly to the first ankle bone. And your fibula is there kind of strapped on with ligament to the tibia. And the fibula is there really not as a weight-bearing bone, but as a bone that you can attach muscles to. There will be an interosseous ligament between the tibia and the fibula, just like between the radius and the ulna. So that's not a blank space there. There will be some nerves and vessels going through that space, but primarily the connective tissue and the fibula are there to attach muscles to. Proximally, the quadriceps tendon attaches and pulls on the bone and creates an enlarged, roughened surface called the tibial tuberosity. And then above that are the tibial condyles for the femur to articulate with. It looks really precarious, the surface of the tibia and the femur. Looks like you could probably have the femur sliding off the tibia with any kind of lateral movement or stresses, but we have intra-articular meniscus of fibrocartilage that helps somewhat with that stabilization of the two bones interacting with each other. And we'll have a medial and we'll have a lateral meniscus that will give us some more stability. These intercondylar eminences, if you're Catholic, you probably know what eminence means, or maybe Episcopalian, because the priest or the minister that is highest ranking, you call that person your eminence, meaning instead of your highness, because you had to differentiate between your highness the king and your highness the priest, so you call them your eminence. So eminence is an elevated something. Here it's an elevated projection of bone. The elevation there is due to ligaments, not muscles, attaching to that point. And when you extend your knee, force is applied to the cruciate ligaments, and you get this elevation in the center area that corresponds with that intercondylar fossa where you have the attachment of the cruciate to the femur. So they will talk in chapter 8 about the cruciate ligaments. They originate on the tibia and then cross, that's what cruciate means, and then attach to the underside of the femur. The backside of the tibia is where the popliteal muscle, which is responsible for unlocking and locking your knees. You're standing rigid, your knees are locked, that's popliteus, and then when you are relaxing your knees, that also is popliteus. It's attached here, and you oftentimes stand with rigid knees, and that muscle really pulls on the backside of the tibia. You get a pretty prominent line there. Distally, both the tibia and the fibula have what the early anatomists thought looked like a little mallet, so they called it malleolus. And the medial one belongs to the tibia because the tibia is the medial bone. And the lateral projection of the fibula past the tibia is also called a malleolus, and that will be your lateral malleolus. The tibia acts, if you're spraining your ankle all the time, if you're rotating out on your foot like that, then weight is transferred to the fibula, but that's not a normal situation. Most of the time you're straight up and down over. You're transferring the weight directly to the first tarsal bone. So the fibula is not acting as a weight-bearing bone. 7 tarsals,
So different than the wrist, there are 8 in the wrist carpals, yes.
I was gonna say, so then how in the POTS fracture does it fracture both the bones?
The POTS fracture is proximal to the malleoli. So what you've done to get a POTS fracture is usually you run into something like the dashboard of a car, that's typical, or something has run into you. I don't know what you run into.
Definition just said both the tibia and the fibula.
Yeah, but not at the malleoli. So it's proximal to, it's the distal tibia and fibula, but it's proximal to the malleoli. Yeah, so it's about the last 1/3-ish, 1/4-ish would be a POTS fracture. Okay, tarsal bones. So 7 tarsals only, but you have 8 carpals. So it's slightly different at the ankle. The rest of the foot is identical to the hand, 5 metatarsals, and then phalanges, big toes, same as the thumb, 2, and all the other toes, 3 phalanges. You have to look really closely at the baby toe because it looks like there might be 2, but you look really closely and there's 3 little tiny phalanges there. The weight-bearing bone in your ankle, the first weight-bearing bone is your talus. So to me, I remember tibia and talus form the ankle joint. The ankle is a hinge joint, like your elbows, different structure, but it's acting as a hinge joint. The only hinge interaction that's available in the ankle is between the talus and the tibia. It has a nice rounded area to articulate with the tibia. It's named a trochlea, so that tells you, do you remember the elbow? Trochlea means hinge. So trochlea of the ankle is between the bone that has a trochlea, the talus, and the tibia, which is proximal to it. The talus also forms 2 other joints that are gliding joints. One is with the calcaneus, which is underneath it, and then anteriorly with the navicular bone. And navicular translates to little boat again. Used to be that the wrist, the scaphoid was navicular, and also the foot was navicular. And people say, oh, he fractured his navicular, and they wouldn't know where to look. So they changed the wrist to scaphoid, which also means little boat. And then now you know if you fractured your scaphoid, which is more common than fractured navicular bone, and you fall on your outstretched hands, you fracture the scaphoid, then you know it's a wrist problem and not an ankle problem. So there's a sub-talar joint that is between talus and calcaneus. Calcaneus is what you stand on, you rock back on your heels, you are rocking back onto the calcaneus. There's some movement when your foot turns in and out at the subtalar joint, and then also forward at the talonavicular joint. The navicular bone articulates with 3 wedge-shaped bones. So cuneiform, in the olden days you had to learn cuneiform writing and cursive writing. Cursive was the script, and cuneiform was the wedge-shaped writing, which was your all your capital letter types of writing. So cuneiform, wedge-shaped, that's how I remembered it, but you guys don't have to learn, you don't learn the wedge shape, you don't learn cuneiform, I don't think. You have kind of a conglomeration of things that you've learned. Okay, so cuneiform means a wedge shape. It looks like the doorstop that's out there.
bigger on one side, slanting towards the opposite side. The cuneiform bones here, one is broader on the top and wedges to the bottom, and the others are broader at the bottom and wedge to the top. So when you look at, sorry, I got that backwards. So turn your head upside down and look at it again. So broader on the bottom, wedging to the top, and the others are broader on the top, wedging to the bottom. So one that is medial, one that's lateral, and one that's intermediate. So 3 bones, intermediate, lateral, and medial cuneiform bones. So medial is the one that wedges up, and the other 2 wedge downwards. And then the last bone has approximately 4 equal sides, so it's called the cuboid bone. The cuboid will articulate with the calcaneus. It will also articulate with the 5th and 4th metatarsals, the lateral cuneiform with the 3rd, the intermediate cuneiform with the 2nd, and the 1st cuneiform with the 1st metatarsal bone. And then the phalanges all the same as the hand. This little bump there, that's a sesamoid bone that develops in the big toe. If you look at the hand, there are generally sesamoid bones associated with the thumb as well. Anything that's used very repetitively with a lot of force, like your big toes and your thumbs are, those will develop some smaller sesamoid bones, not as big as the patella. If you look at the bones from underneath, then you can see that the intermediate and the lateral cuneiform are wedging down, and this is broader and narrower on the top, so it's wedging upwards. The cuboid, it doesn't really have 4 equal sides, but it has enough of 4-sided structure to, I guess, be able to be called a cuneiform. I'm sorry, a cuboid bone. This 5th metatarsal, I always wondered, I don't know if you ever have wondered why you have this bump on the side of your foot. It's like, what the heck is that? It's nothing abnormal. Everybody seems to have it. But if you get shoes that fit wrong, it just really rubs there. And I never understood until I took anatomy that it was this weird type of articulation with this cuboid bone, that you have this 5th metatarsal sticking out there and causing that bump on the side of the foot. Notice all these little round bones at the big toe underside. Those are more sesamoid bones associated with the big toe. If you really use your toes a lot, you probably will develop sesamoid bones in the other joints as well. But usually between the metatarsal and the 1st phalange, then you'll have a series of these sesamoid bones in the foot. The bones naturally, with their articulation, form longitudinal and also medial to lateral arch. Here you can see the subtalar joint, and then the calcaneus and the cuboid joints, the talonavicular joint. You look medially, you can see the longitudinal arch a little better, and also this medial to lateral arch. You can call it a transverse arch if you want to, but it's really not in the transverse
plane, so to speak. The alignment of those bones are maintained by the strength of the muscles in your foot and also the ligaments in your foot. If either the muscles or the ligaments get stretched out and weakened, then you lose the longitudinal and this transverse arch. In the olden days, probably maybe your grandparents' day, anyway, any relative who was subject to draft for Vietnam War, they used to, and in World War II too, but I don't know if you have grandparents that old. So, but in the old days for draft, they used to set you as 1A, meaning, you're the best candidate and we're gonna take you first. And then it went down to 4F, which meant I'm not gonna take you at all because there's too many physical problems usually. And if we take you in and these physical problems manifest and then we have to discharge you with a medical discharge, is costing us a lot of money. So we'd rather not bring you in at all. So the olden days, one of the deferments would be a 4F status because they would ink the bottom of your foot and then have you step on a piece of paper. And if it looked as though you did not have a longitudinal and transverse arch, they call that flat-footed. And if you really truly were flat-footed, and they put 70 pounds on your back, and they put these non-supportive military boots on you and said, okay, go hike 70 miles, and I guess it was a 40-mile hike with a 70-pound pack. By the time you get back, if you don't have the right support for your arches, you'd be in excruciating pain. You'd have to go to the hospital. They would have to put you on medical leave and eventually discharge you. So if it appeared as though you were flat-footed by this process of inking the bottom of the foot and standing on paper, if the medial part of your foot touched the paper, 4F status. So actually my brother was put on 4F status because of this. And I'm thinking to myself, this was before learning all of this. I was like, I don't think he has flat feet. He's a gymnast, he's a swimmer, he does all these very athletic types of things. Certainly if he has lack of longitudinal and transverse support for his foot, it would show up during those types of activities. So I always wondered, what was going on? Then I learned about this and it dawned on me, hey, he doesn't have flat feet. He's got extra fat in the bottom of his foot in this longitudinal arch. And so it appears that he's flat-footed, but take an x-ray and nothing's wrong with his feet. So luckily they changed the whole draft thing, and by the time they found out that most of the people who were 4F were perfectly normal in their feet and wouldn't have had a problem, then they changed the conscription to voluntary. So those people, I don't think there is such a thing as 4F. There might be deferred for medical reasons, but there's no draft status anymore. So I was thinking, my brother lucked out. You didn't have to go to Vietnam. I apologize to anybody who has relatives that went to Vietnam, but I wouldn't have wanted my brother there, even though. Anyway, enough of that. So anyway, a lot of people got this 4F status because they had this extra fat in the longitudinal arch. Now, they won't give you that diagnosis until they take an X-ray. Okay, so skeleton reveals a lot of things that are important about an individual. People who are of African American descent, they're going to have heavier skeletons, and they will have more prominent lines because of more dense muscle mass pulling on the bones. Caucasians have little more dense bones than a lot of Asians. So Asians, smaller status. There were a lot of things early on too that interfered with the skeletal potential of Asians, and that they didn't have access to a lot of the high calcium types of food, wasn't part of their diet. But once they had that access, then they tended to catch up to the Caucasians, but still not get as dense bones as Caucasians. And then Caucasians never caught up with African Americans. There are probably some African Americans with enough Caucasian in them to have less of the dense bones. And there are probably some Caucasians who then are more or less equivalent. But race does play a part in the skeletal density. I remember when I was trying to teach lifeguards, I was doing lifeguard training, WSI. We had one African American in the group, and that guy, he went into the water, he went down, just straight down to the bottom of the pool, and everybody's going, oh my God. And so we're all jumping in to pull him out, and we pull him up, and he's kind of spitting water, and he says, I knew that was going to happen. And we're like, huh? And again, before this training, and he says, yeah, I sink like a rock all the time. And then we find out, yeah, his bones are denser, and he's also got huge muscle mass that's also very dense. Very little adipose, so there's nothing that floats. So unless he inflates his lungs and knows how to swim to counteract the negative buoyancy, he just goes to the bottom of the pool. And so we said, well, how are you going to pass the WSI test? Because you got to swim, I think it was 500 yards. He goes, I can't think I can do that. Turned out he could not do that. He was strong enough, but he didn't have the technique to learn that. So he had to learn how to swim and then come back for WSI training. One guy, my buddy that was helping me teach that course, Filipino ancestry, he doesn't have the bone density of the African American, but he had the muscle mass. So all he did, he said, you want to see me sink like a rock? And I know he can swim quite, really good swimmer. All he did was deflate his lungs in. He went also down to the bottom. So it wasn't the skeletal mass, it was the muscular mass for him. He is now a thoracic surgeon. He doesn't work out that much. He has a lot of adipose, and so he floats very well now. Okay, medical history. If you're on medications, or if you have a disease that interferes with mineralization of your bones, you will have more porous bone. So you have osteopenia or osteoporosis. So medical history will play a big role in the density of your bones. Weight, the more you weigh, the denser your bones are. Now, people who weigh 400, 500, 600, 700 pounds, if they are so big they can't move around, then their bones may become less porous. But somebody like Robert Kikaula, he's pretty big. I don't know how much he weighs, but I would guess he's over 300 pounds. He is very active. It's amazing how physically active he is at his size. I bet you he's got a very high bone density because of that extra weight he's carrying around. And they've looked at females who are overweight, 200, 300 pounds overweight, but still physically active. Their mineral density for their height is much higher than somebody who's of the same height, same ethnic extraction, but weighs a normal weight. So weight does play a part in the density of your bone. Men with higher testosterone going to have a greater bone density. So with more testosterone, a bigger body size, you have that also adding to the mineral density, and then muscle mass. Pulling on the bone increases the bone density. As you age, everything kind of goes down the other side of the bell-shaped curve, and unless you maintain your physical activity, you're going to start to lose mineral density. And that's when you start to shrink as you get older. You'll find that you used to be looking down on or on some structures in your house, and all of a sudden now they're up to your nose level, and eventually they're going to be taller than you are. And that's because you lose the mineral density and the bones start to get compressed due to gravitational forces. Okay, so chapter 8. So articulation, that term articulation, anything with arth in it is referring to joints. So arthritis is inflammation, itis is inflammation of the joints. So we'll be talking about various types of arthritis. When you do surgery with inside the knee, you use an arthroscope. So something that goes in and looks at the inside of a joint. So joints are articulations, connections between bones. They don't have to be movable, but most of the joints in our body are freely movable. And we'll talk about the various classifications. So some, they may be held together by dense connective tissue and not movable at all, or just barely movable. So we'll talk about those classifications. Anything with a synovial membrane is going to be a freely movable joint. That synovial fluid decreases the frictional force that will increase the free movement of a joint. There will be hyaline cartilage present, either by itself or in conjunction with a fibrocartilage for more stability. With the synovial fluid, that is the way you get nutrients and waste products in and out of the articular cartilage. It's via diffusion into the synovial fluid, and then weight bearing. When you bear weight, the old stuff comes out of the cartilage, and when you take weight off, then the cartilage kind of sucks in the good stuff, and then it has the nutrients for maintaining its structural integrity. If a joint is held together by cartilage itself, those are usually could be a fibrocartilage, like between your vertebra, or at the pubic symphysis, or it could be at your growth plates, and then it's of the hyaline type. So classifications on the test, if I ask you what classification is this type of joint, then you want to know the terms that describe immovable or freely movable, slightly movable, that kind of thing. And some immovable joints or slightly movable joints, if they're in a particular area, may have a specific special name. For example, the joint between your teeth and the bones of your jaw, that's a gomphosis. That's only between teeth and bone. So you won't find a gomphosis anywhere else in the body. So immovable joints, you put the joint together with something that prevents movement. Then the term syn means to put together. So syn means you're putting something together. If it's a synarthrosis, it's an immovable joint. There's a special classification of that where you put it together with bone and you don't even see that the joint ever existed at all. In the frontal bone, where you had those fontanelles coming down and forming a little plate of cartilage between the two ossification centers in the frontal bone, you had a suture, and then that suture disappeared because you had a synostosis form. So you're putting things together, and I just changed the battery. Okay, so you're putting things together with bone fusing bone together. If you put a joint together with cartilage, like at the growth plate, that's called a synchondrosis. So chondroblast, chondrocyte, chondro means cartilage. You put bones together with cartilage and you have a synchondrosis. You put it together with bone, you have a synostosis. If you put it together with ligamental types of structures, then you could call it a syndesmosis. Here it's a specific type of immovable joint, so it's a gomphosis. The ligament is your periodontal ligament that will be going from your tooth into your bone of the maxilla or the mandible. Sutures, they're also put together by dense connective tissue, and so it could be called a syndesmosis for the dense connective tissue. Those normally don't move until you break that connective tissue. So if you're forming a Bouchain skull where you put the moist wood chips in and then heat them up and they expand, that pressure will snap all the attachments between bones, any sutural type of attachment, and then the bones will come apart. But that takes a lot of pressure for those joints to separate. So a synarthrosis, you can put it together with, you can have that immovable joint formed by bone, by cartilage, or dense connective tissue. All of those would form synarthroses or immovable joints. So examples that you're given here, a gomphosis, a suture, those are synarthroses. So diarthroses, those are your freely movable joints. So these are where you have a synovial membrane and you have articular cartilage, and those two things working together create a low friction surface for the bones to move on over each other. So all diarthroses have synovial membrane. Sometimes they just skip the diarthrosis and just say it's a synovial joint. So if you work in orthopedics, they usually don't talk about diarthroses. They just talk about synovial joints. So you skip that one definition and just go directly to what matters. You have synovial membrane and you have synovial fluid. So all synovial joints will have these characteristics. They'll have a joint capsule, and the synovial membrane will line the joint capsule. So it's on the inside of the joint capsule. It will secrete the synovial fluid into the joint space. The freely movable joints will have to have articular cartilage, and it usually is hyaline cartilage. And sometimes there will be fibrocartilage in the joint, but at least one of the bones will have hyaline cartilage on its surface, and maybe the two bones, the other will have a small amount of hyaline and then fibrocartilage, or maybe the two bones both have hyaline cartilage, but there's a disc of fibrocartilage in the joint.
So you can have intra-articular cartilage that will help with the stability or form special types of freely movable joints. So the lining of the capsule was the synovial membrane, which secreted the synovial fluid into the joint cavity. There will be accessory structures for freely movable joints, maybe intra-articular cartilage. Maybe you're going to have a bursa associated with the joint, and you might have fat pads associated with the joint. So there are various accessory structures, could be intra or could be extra, meaning outside the joint space. The cruciate ligaments, those are accessory structures that are inside. And then the same knee will have ligaments on the outside that are considered accessory to the joint itself. They all will be innervated by sensory nerves so that your brain knows what position those joints are in. Because if they come out of alignment, you have to make muscular adjustments to get them back in alignment. If you don't make those muscular adjustments, then these freely movable joints will start to have bad forces applied to them, and they may start to wear out and cause structural instability. The blood vessels will go to the synovial membrane and the joint capsule, but they do not go into the joint. So the hyaline cartilage and the fibrocartilage that are intra-articular are only getting nutrients via diffusion. There will be some blood supply to the epiphyseal bone, but that's very limited after the epiphyseal plate fuses, and will reduce probably to 7 to 10% of the original blood supply to that epiphyseal bone. And amphiarthrosis is slightly movable. Syndesmoses can fit into that category as well. And so when you have just ligament holding bones together and they can move a little bit more than the ligaments that hold your gonfalces together and your sutures together, when it's slightly movable, like at your acromioclavicular joint, then you have a syndesmosis between your ulna and your radius, where you have to rotate the radius over the ulna, and you have that interosseous membrane. That is a syndesmosis. And then fibrocartilage at the pubic symphysis or between your vertebrae, there's slight movement there, so you can call these syndesmosis or amphiarthrosis. So a typical joint will have articular cartilage. There will be a joint space, but there will not be a space between the articular cartilage unless you pull the two bones apart. So you can separate the articular cartilage. But in the normal situation where you have normal muscle tone, the two surfaces are against each other. There will be a thin layer of synovial fluid between the two surfaces, but the surfaces are in contact with each other, except for that thin layer of synovial fluid. What the artist probably was looking at when they interpreted this picture was an x-ray. And you take an x-ray of a joint, the articular cartilages are next to each other, but it looks like there's a blank space there because x-rays go right through cartilage. So a lot of people get this misconception that the bones are actually separated by a distance from each other, and in fact they are not. they're right in contact with each other. The synovial fluid secreted by the synovial membrane, which lines the joint capsule, but does not come in contact with the articular cartilage. If it does, there are cells in that synovial membrane that will end up destroying the articular cartilage. And this is a major problem when you have inflammation of the synovial membrane in rheumatoid and sometimes osteoarthritis, that the membrane gets swollen enough that it comes in contact with the articular cartilage and then starts to break it down. This joint here, femur and tibia, there's this little, it looks like just a little piece of a meniscus, but there's actually a ring of fibrocartilage in there. It's just that you cut down the middle of the two bones, so you only see part of the meniscus. And then some more of the meniscus there, and some more of the meniscus in the front. The intercapsular ligament there, so that's your cruciate ligaments. Here's a fat pad, that would be an accessory structure. It will protect the tibia from the patella, and the patellar and tibular, femoral hyaline cartilage will move over each other. Up above, more fat pad for protection, and then there will be various bursa that are in front of the patella, behind the patella, behind the femur, behind the tibia, in front of the tibia. They will all be, bursa are generally there as little pillows of synovial membrane with synovial fluid in them to protect the tendon that are running over the bone so that they don't come in contact with rough bone and then get worn out, shredded, and fall apart. So bursa are there for protection for the tendons of the muscle, but they can, if the joint is unstable because the muscles aren't properly strengthened to support the joint, then the bursas get too much pressure applied and then they get inflamed and you have bursitis. If the tendon itself becomes inflamed, then you have tendonitis. So synovial fluid, three functions. It's there to lubricate the surface, and it's very slippery. So it's very good at decreasing frictional forces between the two articular cartilage surfaces. It also brings all the nutrients to the cartilage and removes all the waste products. It's also a good shock absorber. If you've played with egg white, try to squeeze egg white between your fingers. It pushes back on your finger, and also it kind of squishes out between your fingers. It's very slippery. Synovial fluid kind of has that consistency of egg white, in that it's compressible and also very slippery. And the color of egg white is about the color of normal synovial fluid. It should be on the clear side and slightly yellow, but not really yellow, and it should never be opaque. It should always be translucent. Okay, joint movements. So for those of you who are in KRS, this is going to be reviewed. For those of you who are bio majors, it's going to be brand new. So you have to remember joints are, you're moving from anatomical position. So if you're moving in the plane of anatomical position, you are doing abduction and adduction. If you move out of the plane of anatomical position, then you're doing flexion and extension. And if you go beyond, then it's called hyperextension. If you look at the first picture, your wrist starting at anatomical position, if they come forward, they're flexing. But also if they go backwards, they're flexing. So you call it palmar flexion, and then you call it dorsiflexion. So flexion forward, most correct would be palmar flexion. Going back to anatomical position, that is extension. Most correct, the hyperextension of the wrist is dorsiflexion, so dorsal surface of the body. Neck, coming out of anatomical position forward, forward flexion. Come back to anatomical position, extension. Going beyond, that's hyperextension of the neck. Don't call this motion dorsiflexion of the neck. You call it hyperextension of the neck. So there are some things that you can't just go diddle mark all the way down. So most of the time the wrist is referred to as dorsiflexion, and this is hyperextension of the neck. Elbow can only flex and extend if you have a mismatch of the ulna, the olecranon process and olecranon fossa. The elbow does hyperextend, but that's not normal. So flexion and return to anatomical position. The hand is not in anatomical position, so technically that's not extension. Hips, flexion is coming forward out of anatomical position. Returning to anatomical position is extension, and then going beyond that is hyperextension. But there is only 10 degrees of hyperextension at the hip. So what they're showing you here is about 45 degrees of difference from anatomical position. That is not hyperextension of the hip. Only the first 10 degrees are hyperextension. The rest of the movement there is due to changes in the position of the pelvis. When you're walking forward, you anteriorly tip your pelvis forward, and so you get more extension in the hip, but that's not true hyperextension. You contract all your extensor muscles and you move your hip back. That is all you get. Any further, you've got an anterior tilt of the pelvis. Will Martini pay attention to this? No, he will not. But go down to Dr. Prince and talk to him about it. He will agree with me. This is one time I'm sure he will not have any other ideas down there. So 10 degrees of hyperextension is the max at the hip. Okay, so for fingers, you can say abduction and adduction, that's fine. For the wrist, do not say abduction and adduction of the wrist. Because if your hand is not in anatomical position, those terms do not apply. So if your hands are out in front and you go towards the thumb, that is not abduction. It is in anatomical position, abduction, right? Away from the midline. Adduction, away from the midline. Bring your hands out in front, palms down. You're doing the same motion, but it is no longer abduction. Even with your palms up, that's not really abduction anymore. It's a horizontal abduction, but it's not abduction anymore. So the best thing for the wrist is referring to where the wrist is moving, in what direction, to the ulna or to the radius. So radial deviation, ulnar deviation. If you're going to physical therapy school, you're going into medicine, pharmacists might not have to know this, but other people will have to know. And radial and ulnar deviation are the best description of that movement, not abduction and adduction. That only applies in anatomical position. Hips
adduction, abduction is fine. Shoulder, abduction, adduction is fine until you come out into the horizontal plane. Then you have to describe it as horizontal flexion, horizontal extension, or horizontal adduction, horizontal abduction. So there are exceptions. On the hip also, you can, if you're strong enough, you can bring it up in front and move it side to side and across. So you have horizontal movement of the hip as well. Circumduction is when you have the joint able to flex and extend, abduct and adduct, then you can connect the 4 dots and get circumduction. So if you abduct and adduct, flex and extend, then you can connect the dots and you can get circumduction. So you might have a joint that only has 2 planes of movement, but you can get a whole 3rd function out of it by connecting the flexion and extension, abduction and adduction together. Rotational movements can occur at the vertebral column. You can also get rotation of the radius over the ulna. So that will be pronation and supination. The rotation, the dot here is at the shoulder. So that will give you internal and external rotation of the shoulder, also called lateral and medial rotation. To be start in anatomical position, you're already pretty much laterally rotated at the shoulder. You can't go much beyond that. You can turn the palms in and go back. That would be medial rotation. You start in anatomical position with the lower extremity. You can turn out. You can turn back to anatomical position. You can also turn in somewhat. So the hip is triaxial. It can abduct, adduct. That's one plane of movement in anatomical plane of motion. Can come out of anatomical plane into flexion and extension. And it can also just sit there and rotate inwards and outwards, or medially and laterally. So shoulders and hips, when they are ball and socket joints, they have 3 axes of movement. So rotation, flexion, extension, abduction, and adduction. So pronation and supination, that is a rotation of the radius over the ulna. And then pronation, the radius goes over the ulna. Supination, you come back to anatomical position. That's one of the reasons why the palms are facing forward in anatomical position, so that the 2 forearm bones are parallel to each other. If your palms were at your sides, then the radius is already partly rotated over the ulna, so the bones would be somewhat crossed. So palms rotated forward, bones are parallel, that's your anatomical position. I haven't checked the current textbook, but I doubt if Martini has changed this. You can check it out. But what he's showing here, and labeling an eversion and inversion. You have to remember inversion and eversion are from anatomical position. So the foot has to be flat. So if the foot is up, and it's in a flat position, the toes are pointed straight up. He's showing the foot already in plantar flexion and then going in and out. And that is a movement of the ankle, but it's an abnormal movement of the ankle. So true inversion, you have to start with the foot flat, bring the medial edge up, Then your foot is up here, bring the medial edge up, toes pointed up, that's inversion. Turning the lateral edge out with the toes pointed up, that's eversion. But not with the toes pointed,